Got
So
it.
we all can hit continue to click to authorize it. So Jana, my name is Steve Andrews. I'm the,
Hi there, I'm gonna put you up to it now. We just started recording, bye-bye. I mean, hold on.
I'm the chairman of the DD Council, and I'll let the other members introduce themselves.
I am Patty Uplinger and a member of this council. And I just started a new job at STEP as housing coordinator and just got housing access services as well, contract. So I'm creating a department, housing department at STEP and hiring a few people eventually. So and here I thought I was gonna like take it easy and retire, but now I gotta work hard for about 3 more years.
Wonderful.
Congratulations, Patty.
Thank you.
Yeah.
It's something that, I looked at advertised for a housing coordinator position in 2001. I applied for it then and they never filled the position.
Call you just a sec.
And so 20 years later, here we are.
Destiny, right?
It took a little time to advocate for this position. So what's 20 years?
I'm
Gina,
Maureen. I'm
Go ahead.
Maureen. Go ahead.
Go ahead, Maureen.
I'm Maureen Fitzgerald, and I'm just a retired person who keeps trying to stay in the field and see what we can do better for our folk and for the families supporting them. Let me let Patty Pacheco on the phone talk. Go ahead, Patty. Can you folks hear her?
No.
She said, "Hi, Sue Gilmore, welcome back."
Thank you.
She said, "Thank you."
Sue, go right ahead.
Okay, Sue Gilmore, principal at, or director of adult ed for Sac City and administrator at A. Warren McClaskey Adult Center. And I have been on health leave for, 2.5 months or something. But I am back half-time and glad to be here and glad to be with the students. And we do have a combination of Zooming and in person. Some families didn't want their,
You hear? Good. Okay, I'm putting it back.
some of the families did not want their children coming back. So we're just Zooming with them. And then we need to keep 6 feet apart and masks on. And so our classes with 10 students, they can all be here. But the classes with 24 or 25 students are splitting days. And so they come either Monday, Wednesday, or Tuesday, Thursday, and then Friday we do only Zoom.
Nice to have you back. I'm
Good.
glad you're on
Good
the
deal.
healthy track.
Bonnie,
your turn.
Okay, I'm Bonnie Douglas, Program Director at TSS. Jana is familiar with my program and my services, so thank you so much for joining us.
Good.
Thank you for inviting me, Bonnie.
What did you say, CSS?
All right.
Bonnie?
And Jana, why don't you introduce yourself?
Sure. So my name is Jana Cooper. I work at Turning Point with Bonnie, different program. I've been with Turning Point for 17 years now, and we just started the new START program, which I'm here to talk about today. And we started in January of this year, taking clients like January 28th. So it's a new program and we're getting up and running, and we're doing a lot of outreach to sort of get our name out there and to start collaborating with our community partners.
Good. And you started what, in January of this year?
Yeah, we were awarded the contract last year. It took a few months, longer than I thought it was going to get our the program design, our contract, and everything kind of settled. So we actually started taking clients at the very end of January, actually before we even had a contract, just because we were bored and we wanted to start serving clients. So we did a month for free. So yeah, we're getting up and running, and we have a census of around 40 now, and ultimately we'll have 150.
So 40 people right now, but you can have up to 150?
Yep. Yep.
Great. Okay. All right, let me take care of some housekeeping things first before Jana starts discussing her program in depth. I did email out the minutes for the April DD Council meeting. Do I have a motion to approve it or modify the minutes?
So move. Patty Pacheco just seconded.
Okay. All documented as being approved for April 21st then. All right, so we do have a new executive director that's going to be starting. And is it July or the end of June?
June 19th.
So that's what, Friday?
Yeah, that's
Is
what
It's
the-
Friday, yeah, okay,
Delta?
the announcement.
yeah. And Maureen, thank you very much for sending me that email that you got from Lisa West from Alta Regional from the board.
Do we know who it is?
So it's going to be, Lori Benellis is going to be the new executive director.
And my thinking was,
I guess we all saw that coming.
for the time that Phil served, 15 years, and the things that have improved from way improved, it was a disaster ship when he came on, but I thought the council could send a note congratulating Phil on his 15 years and retirement, and then also conversely send a note to Lori congratulating her and welcoming her on board, and our offering to please view us as anything we could assist on, we'd be glad to help.
I'll definitely approve that.
Send those two letters from the council.
Do I have a second?
Second,
Good. And Maureen, can we do that, what, by tomorrow?
Yeah, we got to get him right out so Phil gets his while he still has email.
Yeah, and you know, the same thing with Lori. I did send Lori a private email yesterday congratulating her when I got the email from Maureen. And I'm really glad to say she responded. So
Oh
I'm
my
hoping
God.
that we can turn around and have her be, you know, attend some of our DD council meetings in the future. So, and I told this to Sonia earlier, I really think her and John Decker are really going to be a good team.
John's great.
Yeah, so I'm happy about it. Good.
I'm glad he didn't go step up to director. So
I'm sorry, I can't hear you, Patty.
I think John's good in his position. Can you
Yeah,
hear me?
yeah. John has done an excellent job with the whole COVID virus vaccine thing and everything else. He's networked with a lot of people, and I think has really gotten a lot of people the vaccine because of his ability to network with everyone. So, good. All right, any other housekeeping things we need to discuss? No?
Can I make
Okay,
a quick
Jana, you got
announcement?
the floor.
Oh,
I'm
can I
sorry.
make a
Go on,
real quick
Sonia.
announcement? I just wanted to remind people that tonight we have a dental workshop for regional center clients, specifically from Alta. So we have a lot of people registered. So we know there's a lot of interest, and I can try to put the flyer in the chat, but you're welcome to attend. It's tonight from 6 to 8. It's really meant for family members and self-advocates to understand the regional center's role in accessing dental care when you're on Denti-Cal. And Liberty Dental will be kind of explaining to people how to use their plan and access their plan. And the regional center will be a big part of the presentation. So anyway, welcome to spread the word and attend if you'd like. I will share the link. Thank you.
Good. Sonia, can you email the flyer to my work email?
Yes,
Because then this way I can network with all of the parents at the
Yeah.
Short Center South Day program for them
absolutely.
to attend it. Great, thank you. All right, Jana, with 17 years experience at Turning Point, you got the floor.
All right. Can I share my screen? Is that possible? Oh, yeah, now I can. Thank you. Sorry, shared to the wrong. I have 3 monitors going in front of me, so if I'm looking up in weird directions, that's why. Okay, what do you see? This is a test.
We can see it.
You
We
can see
see
the PowerPoint?
your, we see your PowerPoint.
Oh,
I see the
awesome.
chart.
Yeah, we see it.
Okay, so the START program. First thing I usually get asked is what does START stand for? So it is an acronym. It stands for Systemic, Therapeutic, Assessment, Resource, and Treatment. And that kind of encompasses all the areas that we cover. So START is a comprehensive model of service, supports, optimizes independence and treatment, and community living for individuals with IDD and mental health needs. And so why START? So this is kind of our foundation about what we believe.
Jana, this is Patty. And it's not going through the PowerPoint. We see the PowerPoints on the left-hand side, all the slides. And so your introduction slide is still the main slide.
Okay, let's see.
That's just, you need to like run the program from beginning or something, I guess.
How about now?
The first slide.
Click the from beginning button on the far left of your PowerPoint.
You can't see the second slide now?
No.
No.
Just in small, they're just on the left in the small.
Just on the left, huh? Okay. So, because I can see the full thing. So I'm going to stop. Well,
There you go. That's good.
Yeah,
There.
you got it.
now you can see it?
Yes.
Yes.
Oh, that was interesting. Okay. Okay, so now you can see what START stands for?
Yes.
Yeah.
Yay! All right, thank you. And I'll kind of say in the beginning, please, if you have questions as I go through, just jump in and ask questions. I'm not super formal, so I prefer this to be kind of a conversation versus just me talking at everybody. All right, we went over that.
Can you go back for 1 second? I was documenting that.
Sure. Right there?
No, right there.
Okay. So systemic, therapeutic, assessment, resource, and treatment.
You got it. Thank you.
All right, no problem. Okay, we talked a little bit about this. And so what START believes? So we believe that people with IDD deserve to live fulfilling and meaningful lives in their communities. We also believe that everyone has a path to mental health, and it is our honor and privilege to assist individuals with intellectual and development disabilities on their journeys to wellness and recovery. And so who do we serve? We serve individuals through the Alta California Regional Center. They are our funding stream. And we are referred clients who are experiencing some behavioral health challenges. They may have a mental health diagnosis. That is not a requirement, but they're having some behavioral health challenges that are really affecting their quality of life and their ability to really be stable and to engage in their communities. So some of the things that a service coordinator might consider before referring is if the person perhaps has been to the emergency room recently, or perhaps they use emergency services frequently. They may have behaviors that are impacting their safety or other safety. They may have challenges maintaining their stability in their community, which could be their day program, their school, their living arrangements. Sometimes individuals have a lot of changes in providers, like they just can't quite the right fit on what supports they need. Service coordinators sometimes have questions about diagnoses. I know we've received referrals and we might have 4, 5, up to 10 different diagnoses. And they're really not sure what's going on with the person and they really want to get to the bottom of that. And sometimes they might be like stepping down from a higher level of care and they're really wanting to figure out what kind of services does this person need? How are they going to be successful in their community? And sometimes it's just there's a need for collaboration. There might be several different providers involved, but the providers for one reason or another really aren't able to collaborate and connect with each other. I'm sure all of you have had experiences trying to get a hold of a discharge report from a psych hospital. It's like an act of Congress needs to happen to get those sometimes. So we're really there to really help facilitate that collaboration. So our goals. First goal is to educate. Our goal really is to increase the capacity for our communities to be able to work with individuals who have intellectual and developmental disabilities, as well as co-occurring behavioral health challenges. And we'll talk a little bit more about how we do that, but we do that kind of on a broader scale. So not just about the clients we're working with, but really to help the community just better work with these individuals. Collaboration, we are facilitators of collaboration. When we come onto a case, we are an extra. We're not taking anybody's place or fulfilling any of those specific roles, but we're really coming on to bring everybody together and get everybody collaborating and working together. And when I say everybody, I mean everybody. I just brought a new client in, and we're involving not just the group home and day program family and the people who are around her, but the psychiatrist, the local sheriff's department, the local hospitals that she has gone to. We really want everybody on the same page. The next is crisis prevention, and we'll go a lot more into that. But our goal is to really decrease hospitalization and emergency service utilization. And we really want to keep people in their communities and doing well in their communities. And we do this through planning. We do have a crisis response, but really our goal is to sort of make plans and put things in place to keep people out of crisis and keep them in their communities doing well. And the last one is happiness. Yeah, Steve.
Jana, both Sue and I kind of run day programs here in Sacramento. So if we run into a problem and have a participant who attends our program who's having mental health issues or behavioral issues, can we refer them directly to your program, or do we have to go through the service coordinator at Alta?
So currently we would have to go through Alta.
Okay.
We are putting something in place where we could take a little bit more of a direct route, which you could contact us, like through our crisis line. We would contact the Alta manager of the day, and he could authorize the service, especially if that person is in a crisis. Now, if you're just like, they need some support, they might not authorize it that quickly. But if you're like, hey, the cops just came out, this is a challenge, then they probably would authorize it.
Okay.
Yeah. Okay. We'll talk more about happiness, but really what we're looking at is we want people not just to be like free of the problem behaviors that have been identified, but we really want them to be happy. We want their lives to have meaning, for them to have relationships, to be doing things that they enjoy. One of the quotes I heard when I first started getting into this program was, happy people don't throw chairs. And it's kind of funny, but it's so true. It's like the happier people are, the more fulfilling and meaning they have in their life. That alone could help reduce the crises that we see. All right, so our guiding principles, these are probably familiar to all of you, but we are a very strength-based service, and we'll talk a little bit more about this, but we're based in kind of structural family therapy, but as well as positive psychology. And that kind of goes back to that happiness, is we really want to find out what people's strengths are and kind of what jazzes them, what makes their lives fulfilling. And it's different for all of us, but we believe when people are really kind of functioning in their strengths, they are happier and they just do better. We are very wellness based. So while we are technically a mental health program, we are really looking at that whole person. We have a biopsychosocial approach. So we're looking at the medical needs, the mental health needs, their social atmosphere, their community. We're looking at all aspects of the person and bringing all of that together. A lot of the individuals we work with do have some complicated medical needs. And we all know if you're not feeling well, then nothing's going well, and so we need to look at all those different factors before we make a plan and figure out how we can best serve someone. We really need to know everything about this person and how everything is interacting. I have a good story I'll tell you later about that. We are trauma informed. A lot of the individuals we work with do have a trauma history. Sometimes when we're talking to maybe a care provider, they would say, no, we're not aware of any trauma. But when we really dig into the history, and we do dig into that history, Alta's been amazing about sending us records, and we read them all. A lot of times we find there's been a lot of traumatic incidences, and it may not be the big T traumas, but we're seeing a lot of those sort of chronic traumatic events in the individuals that we're serving. Cultural competence, we have a diverse staff. We value that diversity in our community, and we want to make sure we're serving people in the way that they need to be served. And then, of course, we're very person and family centered. It is all about the people we are serving, for sure. All right, so this is our model. We kind of have 3 levels of intervention. I'll kind of go through each one of these. And I can talk all day, so if I go too far, Steve, just flag me and let me know. I'll speed it up. So we're going to start with the primary interventions. So the primary, as the top of our triangle, these are the interventions that serve the most people in our community. And like I said in the beginning, our goal is to really increase capacity for our community to be able to work with individuals successfully. I know I've heard stories just in starting where people say, oh, well, this person was, referred for therapy, but the therapist was discharged them because they said, they're not appropriate for therapy. And that just kind of breaks my heart because there's so many different ways you can do therapy. And then what it tells me is that provider just didn't know how to provide therapy to this population. And it does take a little, it's a specialty and it takes some extra training. And that's what we want. We want people to feel confident and have the ability to do that. So let's talk about how we do that. So community trainings. We have a variety of different trainings that we can provide. A lot of times we might be providing like specifically for, say, a group home, or even I know like you work at Short Center, we could provide a training to your staff if you had one of our clients, and we could provide a training that's not just geared toward that particular individual, but it might be across the board. So say you had, a newer staff and you realize, hey, my staff could really use more information about trauma. Then we could support you and provide training in that area. We provide monthly community education teams. And what this training is we take an individual we've been working with, and we basically kind of present that individual to the team. And we do it in a de-identified way. So there's no PHI, you don't know who it is. And then we connect a training to it. So we had our first one last month, very excited. And we presented a case, and that training really discussed trauma and the effects of trauma that had on this person. And then after the training, we have a component where we really want to get everybody's kind of feedback and thoughts on it, and even suggestions about what might be the next steps to working with this individual. Because we do find that our community is brilliant in so many ways, and we don't know it all. So the more information we get from others, the better service we can provide. So we have one, I think next week is our next one, and I'll send you guys an invite for that if you're able to attend. And then information START model, I have my dog and pony show. I'm happy to go out anywhere and explain START and what we do, and how we can collaborate and work together. And again, the whole goal is to increase the capacity of our community to work with the individuals we are happy to serve. So again, collaboration, as I said, this is super important to us. We create what's called linkage agreements. And these are kind of agreements between us and another organization where it's just kind of, basically we're putting on paper how we're going to collaborate together. A lot of times we have some great collaboration and great relationships with people, but when that person leaves, we might not have the connection to kind of keep those that collaboration going. So while, Steve and I may have a wonderful relationship and collaborate in a lot of cases, when Steve desires to move to Tahiti and retire, I might not know who to go to, or the person who takes Steve's place might be like, never heard of you. So this kind of puts something in writing about how we collaborate that anybody can kind of get. It's also something you can share with the people you work with, so whoever's on duty knows how we collaborate. And it also holds us accountable for what we say we're able to do. We also have an advisory council, and that's kind of how I ended up here. Bonnie was at our advisory council. And kind of the same thing, we have an advisory council from members of the community from different areas who kind of bring their expertise and sort of help guide us in what the need for our community is. And we'll present our outcomes results to advisory council and make sure that we are doing what we're supposed to be doing. And so they'll hold us accountable as well to our mission and goals. All right. Any questions before I go on to secondary interventions?
Yeah, I have a quick question.
Sure.
On our Nextdoor, one of the apps where people in a neighborhood talk about everything, near me, I think it's the grandmother or the mother of a young adult. He's an adult, and I think he's autism, and the police are periodically called, and then people complain about, I didn't move here to have police. And then the woman apologizes, and I'm thinking, I don't know for sure if he's Alta, but if he is, what should she be doing? I don't know what she's doing, but what could she be doing to ask for more help? Is it something you folks get involved in, or back to the service coordinator, or what?
No, that's a really good question. So there's a couple different routes. Ideally, the route number one is that a person will call their service coordinator, say, hey, we need more support, or we want START, and they'll say, great, fill out the referral, goes to our liaison, and we get the referral, usually pretty quickly. That obviously doesn't always work. Service coordinators are very, very busy. And we're new to the altitude. Not everybody knows about us yet, even though they're learning. And so we do kind of have some other routes as well. So you are welcome to give them my information. They can call me and I will talk with our liaison and we can kind of tag team it, so to speak. She'll reach out to the service coordinator saying, hey, we got this information. And we have done that. We had someone just call me randomly and we got them services within the week. So we can do it that way as well. Service coordinator is always first choice, but you're welcome to pass out my information and I will help support that process.
Okay, I'll reach back to her. I didn't know what to say, but I feel so bad when people are saying, well, they want to get rid of him. I mean, with the police coming and everything, but then clearly there needs to be some help, whatever's going on.
Yeah,
Okay, thank you. That's useful to me.
yeah, absolutely. All right, so secondary interventions. So these are our planned interventions that we're doing with the individuals that we serve. We do a very thorough assessment. We have a lot of different assessment tools that we're doing to really get at historical information, but really about breaking down what's really going on now. We do crisis planning, which we'll talk more about. We do a lot of strength building. We find that a lot of the individuals we're working with are sort of beaten down a little bit, and so are the care providers. And we really want to kind of build up their strengths and sort of support that resiliency building in them as well. We do a lot of teaching, some psychoeducation. We really want to, again, provide the systems that are supporting these individuals, the knowledge and the skills they need to really do this tough job. We have coaching. I'll talk a little bit more about that. It's a little bit more one-to-one service. We also have a duly boarded psychiatrist on staff, and he is not necessarily here to provide services to the individual specifically. He's not prescribing meds or anything like that, but he's kind of our go-to when we need to consult. Like I said, sometimes we get a lot of records in and it's very confusing about the different medications and the changes in the diagnosis. And he really helps us make sure we're really understanding those things well. He's part of our community education team. So he speaks to the medical piece when we're doing our education. And it just really ensures that when we're doing that biopsychosocial approach, that we really are able to address the psychiatric needs as well as the medical needs of the individuals we're working with. All right, so I want to talk a little bit about strength-based service because this is something that we really, this is really foundational, I think, for this program. And one of the ways that we kind of have lived this is not only in our documentation, but in the way we talk and the way that we interact with the individuals and the systems we work with. And sometimes we find that providing that support to the systems has really been beneficial, because sometimes when people are coming to us, the caretakers are really frustrated, they're burned out, you know, and that we start having language that we find is kind of stigmatizing and really not helpful. You know, when they're saying, oh, you know, Jana is really manipulative. It doesn't really help me. How am I going to work with Jana? And it kind of feels icky, like, oh, she's going to be hard to work with. But when we kind of rephrase that, it's like, wow, she's really trying to figure out ways to get her needs met. Then you're like, yeah, yeah, because we're all trying to figure out ways to get our needs met.
Yeah.
Yeah. The same thing, like, you know, they're non-compliant. We told them what they do. They didn't follow directions. And it's like, okay, so you're telling me this is a person who really needs choices. You know, they don't like to be bossed around. They want to make their own choices. And who doesn't? And sometimes just by having systems and people see things through a different light, it kind of gives a little bit more hope and just kind of a little different perspective. Because when I say someone's manipulative, that's hard to work with. When I say she's trying to figure out ways to get her needs met, then you're like, oh, I can help her do that. You know, so that's one of the ways that we really kind of use our language and in the beginning to really support those systems work with individuals we work with. And we also want to make sure that people are sort of using their strengths. We use the VIA Character Strength Survey. There is a link there. If you have not taken, I encourage it. It's great to do with your family, friends. It's a great team builder, but it really identifies what a person's strengths are. And these aren't strengths like, oh, you know, they're really good at making their bed or they're on time for work. You know, these are strengths that are really innate to us about, you know, whether it's a sense, you know, creativity, or they have a very strong sense of fairness. My number one is humor. I make lots of terrible jokes, but when we're engaging in our strengths and we're being able to use our strengths throughout our day, we just feel better. We're happier people. And by knowing someone else's strengths, we can sort of make sure that we're setting up their environment that they're able to use those strengths. And also when we find out that someone maybe, for an example, I have a staff who's, like I said, humor is my number one, and humor is her last. It's her number 24. She doesn't like my jokes. But I know that about her, and I know what her strengths are. So when I interact with her, I make sure that we're working more in her strengths as well. So it's just a better way to really understand kind of where people come from. And instead of thinking, oh, she has no sense of humor, it's I understand her better, and I understand what's important to her. She has a great sense of fairness. So it helps us really appreciate people and what their unique things they bring to the table. So I'm off my high horse on that, but I do encourage you to take it. A lot of fun. All right, so this is our piece de resistance, our cross systems crisis prevention and intervention plan, CSCPIP. So this is our crisis plan. It is a very comprehensive plan. And it's more than just like, oh, if a crisis occurs, this is what to do. It's really about interventions, and it really is about how we work with people. How does this person need us to communicate with them? How do we build rapport with this person? So we talk about their strengths, how they communicate receptive and expressively, what they look like when they're doing well, things they're interested in, ways to build rapport, ways to build their trust. And then we talk about what a crisis looks like for them from those beginning stage 1 phases, when we're just starting to see a little bit, and then how do we respond to that in the best way that's going to support them, and who's going to respond, because sometimes there might be someone else we need to bring in who's really great at responding. And we do that from those very beginning stages, middle stages, to the point that they really are in crisis and we're maybe bringing in emergency services. So it's a very comprehensive plan. And when we create this plan, we're not just creating it here in our little office, we're creating it with everybody on the team. So we want their systems there, we want their school there, their day program. I've had the urgent care hospitals involved. All the people who are kind of involved with this person, we want them involved in this plan, because we're not the experts on this person, but all these other people are. So we're trying to really get everybody together, get all the information, figure out what's working, and put it all in the same place. Because sometimes we find out that a person might be struggling at home, but maybe they're doing beautifully in their day program. So we want to know what's going on in that day program, because we want to take some of those things that are working and bring them in the home. And the same thing, like if a person does end up in an emergency room, we want to have, the emergency room needs to have a copy of this plan too, so they know how to work with this person. So it is very comprehensive. We try to get many people involved. This plan is done probably about a month and a half after we do intake. And then we start editing it as we get more information, as we learn more, as we try things that work or don't work. We're going to be updating this plan so it's accurate. And then everybody on the team should have a copy. Everybody should be in agreement on this plan. And if they're not, then we need to fix the plan. That's on us, not everybody else. Any questions about that? Oh, I said a lot.
This is very comprehensive. Thank you very much, Jana.
Yeah, absolutely. Like I said, I will talk all day. All right, so the next thing we
get to another 10, 15 minutes though.
Okay, I will get there. So next thing we offer is therapeutic coaching. And this isn't for everyone. It's just something that Alta wanted us to provide. And it's a great extra service if a system kind of needs some additional one-to-one, maybe some skill building, maybe a caregiver needs some little extra support, learning how to implement a plan. We can provide that kind of one-to-one support to kind of give them that little extra that they need. Okay, so the final level is our tertiary interventions. These are our crisis response interventions. And we do have a 24/7 crisis response. We provide advocacy. We can do emergency therapeutic services. Means one of our coaches can go out and do kind of one-to-one supports when needed. And we will collaborate with those emergency services. So in looking at our 27 crisis response, we have a coordinator that's kind of our primary position. They are on call 24/7, which means we have someone on call right now. So say a school or a day program or a care provider needed support, they could call us, they would get someone immediately. We can do, kind of depending on where the crisis is, we can do some immediate coaching over the phone. And then we can go out in person one-to-one and provide that intervention and support with whomever that system is. Our crisis is a little different than some other crises in that we're not necessarily there just for the individual who's having the crisis. We're there for the systems who are supporting the individual. So we'll come out and work with the school, the day program, the care providers about intervening and how to best support this person in the moment. We can also go out to emergency rooms and hospitals and support the emergency services with working with this person. If the police were called out, like Maureen, the person you mentioned, if the police were called out and you called us, we would try to get there too, because we want to talk with those police officers and say, hey, this is what's going on. This is how we work with this person. This is really what the need is here. Because we all know that sometimes police officers are going in blind to situations. They really have no idea what's going on. And we want to give them as much information as possible. And I know I've done that with one police officer, and they were super receptive to it, and they were very happy to have that kind of support. And if the person ended up, being put on a hold, maybe taken to a hospital, we will go as well and then work with that hospital and provide that extra level of support. Sometimes our individuals are put in an ambulance and sent off to the hospital by themselves. And that usually isn't the best. And as we know, emergency rooms are crazy busy places, and they're not usually the best place for our individuals we work with to really get better. So we want to provide that support. See, I made it just on time. Any questions?
So the police and sheriff, I would think, as you're saying, would be extremely receptive to having some help.
Yeah, so far they have been, because they want to do what's best for the person. They're good people too. And it's like when we say, hey, this is what works, this is what the need is. And they're like, great, now they know how to proceed. I mean, they still have the things they have to do. If they have to put someone on a hold, they do. But they really do appreciate that support.
Jana, what counties are you covering?
We cover all the counties. Anywhere Alta is, we are.
Okay, great.
Yeah.
That's good to hear.
Is there physical intervention?
We do not do physical interventions, no. That's not really our role. There could be that we're going out to, say, a group home and they do physical interventions, and we're not going to intervene in that. If they're doing what's in their program plan or what is in the person's IPP. But I mean, we will kind of help debrief those situations too. Like if something's not working, then we want to work with that team to figure out what's not working and what might work better.
And this is just, people are referred to, it's not that, like I'm at STEP now, right? And we do SLS and ILS and a variety of things. Would that make sense? Like if we had someone in crisis, I mean, we would probably want to handle it ourselves, but in the case that we had someone in crisis, would we call on START to help us? Is that how it works? Or
no,
you're with people that don't have support?
Yeah, we're a little bit more of a longer term service. So we're usually in there about 1.5 years. So if you had a person maybe coming to STEP and maybe they had a history of emergency services or aggression or behaviors that might place them at risk, then STAR could be a good referral, because we could come in and work with your team and everybody working with this individual and making sure we had a plan in place to manage any situation that might arise.
So you could work alongside STEP staff, for example, in an SLS situation.
Yeah, we're not here to take anybody's place or to tell anybody what to do, but we will kind of help that process. Because like I said, we will do kind of that digging and talking to all the systems that are involved with this person, trying to bring everybody together, get everybody at that table to kind of create a plan that's going to work for this person. I'm actually working with a person now who's coming out of a crisis care home, and they're doing beautifully in this crisis care home, but they're stepping to supported living. And we're very hopeful, but we want to make sure that we have a plan in place that really addresses everything, and that can really support the new staff in working with this person. In addition, we want to make sure that we're putting everything in place in this home so this person kind of has a meaningful life and they have activities they like, they have the structure that works for them. So we're really trying to set this person up for the best success possible. And it's a very collaborative process.
What's the service code?
We're Don't ask me to know the code. We are a crisis service. But I don't know my number.
Well, we have a new program at STEP 017, and it's a mobile crisis unit. And so you're talking about all of this stuff, and it sounds so familiar. And what we're going to be doing, we don't have it implemented yet, and that's how I got hired.
Nice.
John Decker built in a housing coordinator position in the mobile crisis unit. So we've got Dr. Ruth Myers, and we'll have a nurse and I don't know, social worker or something in that crisis unit.
Nice.
I don't know what that's going to look like, and I don't know. That's why I asked service code if you're doing the same thing that we're going to be doing. Like, I don't
It
know.
might be very similar. I'm assuming yours is just for the people you work with. It sounds more.
It's all Alta.
Oh, nice, nice,
5 counties.
nice. Yeah, it's a lot of counties when you start mapping that out.
Yeah.
Yeah.
Well, I didn't know if it made sense for you to do a training for us at STEP. I don't know. I'll see.
Yeah, we could talk more about it.
Yeah.
And see what the need is. And I know, like, you know, there's CBAM, and CBAM has a kind of, it's similar. It's their philosophy is a little bit different, and they're shorter term versus our program is a little longer term. We stay with the individual, and we work on that crisis plan until we have one that works. And that's kind of our goal, is making sure that by the time someone leaves our service, is that they have a system that works, they're doing well in their community, and they're not having those emergency needs anymore.
So you have a POS for to provide a year and a half of service?
It's a year at a time is our service. But yeah, I think the average length is about a year and a half in our service for a successful service. But sometimes cases go longer and sometimes they go shorter. It really depends on what the need of the individual is.
Right. Thank you. And what about your email? Can you put that in the chat?
Oh, yeah.
I'm so glad to hear about your program, Jana. I've had calls from 3 families in the last month and a half who were in crisis with young adult individuals who were, you know, interfacing with law enforcement. I've talked to law enforcement, regional center, and just really having a hard time finding appropriate supports and services, and you know, housing issues and so on. And I believe that I remember hearing that one of them, the regional center was trying to refer the family to START, and I'm not sure what the process was in that, but I'm glad to hear a little bit more about it. So thank you.
Yeah, absolutely. And referrals have been slow, I would say. And I think some of it is just, you know, people learning about START and who's appropriate. And we serve all ages, 6 and up. So we can serve children, youth, adults, seniors.
Good to know.
Yeah, and if you ever have any questions, you're welcome to contact me directly, or a family member or a system can contact me directly, and I'm happy to kind of explain.
You're
And
going to get overwhelmed with emails now. I mean,
That's
I know
okay.
I can think of at least 3 people who are part of my day program who would definitely could use the services. So there's no doubt. Bonnie,
absolutely.
thank you very much for making this connection here with Jana. This
Yeah,
has
thank
been
you,
really, really informative.
One more question. What's the caseload? You say you have 40 people right now in your program. You're going to have 150. So what's that like? Is there a case manager that has a caseload, or?
You know, it's ideally, eventually staff would be able to probably have 25 on a caseload, but really that's some in the beginning stages that are more intense, and then some at the end phases that just might need like monthly check-ins.
Right.
You know, that are about ready to discharge. So they'd have that variety. We also have I mean, this is an evidence-based practice. It's very data-driven, the START program. It's kind of newer to California. It's in like 4 or 5 regional centers now, but there is a huge push for more regional centers to use the START model. So it's a big push in our California community. Started in New Hampshire. It's very popular in New York, Tennessee, Idaho. So we have a pretty big support network, and there's a really comprehensive training program. So the coordinator, who is the main position, they go through a training process and a certification process, and usually it takes about a year to get through that process. So it's usually about a year before they even have a full caseload, because they're in that training process.
Okay, great. All right. Anything else? Our next DD council meeting, I think, will be on July 21st. If anyone has any recommendations on a speaker, you can email Maureen and I. I am really considering of inviting either John Decker or Lori Benellis.
Yeah, Lori, I think would be great.
Well, I'm thinking John Decker too, and have him give us a update on what's happening with the vaccines and program openings and everything else. Because he's been talking about that almost every Friday at 11 o'clock with our coffee meetings. So he might be more informative than maybe Lori, but I'll reach out to Lori and see if she wants to show up. And if anyone else has any recommendations.
I think that it would be great to have John Decker or Lori come to the next meeting. I think I'd be interested in also hearing about an update on program closures, because I've been hearing that there's been quite a few, but it's kind of vague information. And so
Yeah.
it might be helpful to hear who it actually is, so we know who we lost, you know?
Yeah, last Friday at the town hall or the coffee meeting at 11 o'clock, that was one of the things John Decker has recommended, that Alta start a baseline of what day programs are opening, how many days a week,
Mhm.
and how many individuals they're going to allow to come to the program, starting in July, August, and September. So I don't think they really have a good handle on who's opening and who's not yet. So.
I heard AIM shut down, AIM and Associates.
They
Can't hear
closed,
anything.
they closed their ILS, but not their program.
Oh,
But yes, that was 105 individuals in the mostly Placer County.
Right.
Very
You know,
sad.
This past year, council had sent a letter to Alta asking them to update openings and closures. And then Phil Bonet at monthly board meetings, or every other month board meetings, would start giving an update. And he gives us a nod to, at the request of, that the DD council had asked for it. And then at the provider advisory committee meeting last week, Michelle Ramirez and some of the others, they want the information on program closures and openings. So it's such a logical, this has been a forever issue, and we never have data. We kind of let it slip away. And the PAC people wanted to know, why are programs closing? Is it a person retiring from care home operations? Is it they can't get staff? Because that's what we were hearing. Anyway, we were on this early, guys, and I hope that they'll start to come up with some, as John's talking, Decker, you're saying, Steve, some kind of baseline. They need to put that out there.
Yeah.
Or I think it would be
We
helpful.
never did get a baseline on the people who don't have Wi-Fi and internet access.
Well, we'll keep working on that.
Yeah, I know, but I'm just making a statement though, they've avoided that question.
Yes, they did.
So. All right, guys, stay safe. Have a happy 4th of July.
is there any corn yet, Steve?